Welcome to Bad to the Bones, the podcast where we discuss everything related to orthopedics, joint health, and living an active lifestyle. Welcome to another episode of Bad to the Bones. I'm your host, Debbie Rody. Today we're talking about something that affects pretty much everyone at some point in their life, pain. Whether it's chronic pain, back pain, sciatica, arthritis, or just lingering discomfort from an injury or surgery, pain can really disrupt your life. Today, my guest is Dr. Laurence Fitzhenry. He's highly respected in pain management here at Premier Orthopaedic Associates. He's board certified in anesthesiology, fellowship trained in pain medicine. Dr. Fitzhenry specializes in uncovering the root of your pain and developing a treatment plan that gets patients back to the life they deserve. So I'm excited to welcome Dr. Fitzhenry to the show. Welcome.
Thank you very much.
We're so happy you're here.
Good to be here. Thank you.
You know, pain is a huge topic that really comes up often, I'm sure, within the practice. And I'm really excited to dive into that. But first, I'd like to talk about your morning routine.
Yeah.
I hear you do some rowing. Tell us a little bit about that because I'm intrigued. That's quite a discipline.
It is. I've been rowing probably for close to, 40 years.
Oh, my gosh.
I started rowing in college and was able to row through college, through medical school. Took a little time off during residency and when we first came back from Boston, but got back into the swing of things about 6-7 years ago.
Okay.
Since I started here at Premier, and it's been great. So
is it like all weather? Like obviously if the river's a little icy, but like, do you do it in the winter as well?
Yeah, as long as the river's not frozen. I have a general rule of thumb is if it's above 30, we're good to go.
Okay.
If it gets I know it's only 1 degree difference, but 30 is fine, 29 not fine.
That's crazy. And what time of the day is this happening?
Usually up by 5.
Okay.
At the Boathouse by 5:50, stretch a little bit. On the water from 6 to about 7:15, shower and to wherever office I'm going to that day.
That's awesome. I really like that because, as I just mentioned, I think it's a great example of discipline and how exercise ties into your philosophy of helping your patients, reclaim their mobility and such. So let's talk a little bit about, what brought you into pain management. How did you decide you wanted to specialize in helping people with pain?
Well, it's kind of an interesting story. I had did an anesthesiology residency, and I had known about pain management because I worked in the Department of Neurosurgery at University of Pennsylvania. Mm-hmm. And where I met my wife, Mary, she was working with a spine surgeon.
Okay.
And she had always talked about pain management in a not necessarily a very flattering light.
Yeah.
So she worked with Dr. Marcotte, who's a spine surgeon, and when they had people who they just didn't know what to do with, they were just like, we're just going to send them to pain management. And they're kind of just, for me, it just kind of seemed like it was a dumping ground.
Yeah.
So I go do my residency in Boston, and my first month or so, I find out that they have a pain management program. No idea what they did. And I was talking to the director of the pain fellowship, and he's like, well, we do, lumbar epidurals, cervical epidurals, all kinds of interventional stuff. And that was one of the things I really enjoyed about my surgical intern years. I really enjoyed doing procedural related stuff.
Yeah.
So it just seemed like a nice kind of a flow. So I didn't really know anything about pain management until about my first month of the anesthesia residency. Went down to the pain center, did a month pretty early on, and just loved it. I loved just the injections and being to interact with people on a not necessarily like an anesthesia. You see them, you put them to sleep, you wake them up, they go to the PACU, and you never see them again.
Yeah.
So it was nice. It was a nice combination of having people seeing how and watching them progress through the process.
So you just mentioned understanding pain management, and that was intriguing to you. Let's talk about that for our listeners. A lot of people when they think of pain management, they're thinking, I'm just going to get prescription medicine. What is a good way to share with our listeners what pain management or interventional pain management involves?
So interventional pain management, there's basically within pain management, I kind of, and Rita knows this and other people know this as well, I talk about it kind of like a soup to nuts. Where I did my residency and fellowship and the pain fellowship, we basically took anybody that was, whether it was medication management, basically all the way up to anything to keep them away from the surgeon.
Yeah.
So whether it was medication management, physical therapy, doing injections,
Yeah.
spinal cord stems, anything to kind of keep them from the surgeons. They didn't have to have a fusion or what have you.
Yeah.
So pain management is really not just medication management. I know there's very stigmatic out there about, pain management. Everyone thinks you're just going and being sent to a pill mill.
Right.
Right, which is
Yeah.
obviously problematic because that's
Yes.
not what it is.
Yeah.
I mean, we have people that in our group that just do medication management,
Yeah.
but they do that in conjunction with myself and the other interventional pain physicians. They work with the meds, we work injections, we have a couple of spine surgeons. It's basically a team effort. So it's not just pain management. It is not just a dumping ground where we're sending people just
Yeah.
for medication management.
Does a patient get to choose the direction they want? In other words, if a patient comes to you and says, you know what, I just want to be prescribed opioids. I just want to go that route. I don't want injections. Is that something that a patient is able to do?
Absolutely.
Oh, wow.
I always give patients an option. I say, listen, they come in, they see me, go through their history, go over MRIs, x-rays, what have you, and I kind of lay out their options for them. Like, here are your options. A, we can do nothing. B, we can send you to physical therapy. And when they come back and if they're like, this isn't really working, I say, well, the options are we can try injection therapy, we can get you a surgical consult, or we can just have you see one of the persons in our group that just does the medication management. I just basically give them the option. So people really kind of drive. I like to tell people I make recommendations and people make decisions.
Yeah, that's a nice way of putting it, I guess. I mean, if you were to talk about some of the most common conditions that you treat, what would they be?
I would say the most common condition I treat is basically low back pain, radicular pain, more so than neck. For every, we'll say, 10 lumbar spine people or low back issues, I'll see 2 or 3 cervicals and maybe a couple of thoracic. But the most common complaint is basically people coming in. And you would think it'd be people coming in more like, I was just having like a 2-week history of back pain and pain going down my leg. The more I shouldn't say popular, but the people that come in the most are the people that like, look, I've had pain 3 to 5 years.
Yeah.
It's on and off. It's gotten progressively worse over the course of the last few months, and it's really starting to impact my activity of daily living, and I'm not able to do what I want to do anymore.
Right. And are they coming to you? Someone can just come to you directly, right? Schedule an appointment at Premier and say, I'd like to see Dr. Fitzhenry for
100%.
pain management. Yeah. So when they do that, when they come to you, what is the evaluation and symptom mapping process, if you will? How does that go?
Well, so basically people will come in, and usually we have x-rays when they come in. X-rays are just, standard stuff, right? We just want to make sure there's no significant bony abnormalities.
Yeah.
So the patient will come in and they'll tell me their history, and I'll ask them some more specific pointed questions about low back, right side, left side. Is it radiate? Is it right leg, left leg, both legs? If it does go into the leg, front of the leg, back of the leg, side of the leg, just try to get an idea for where their pain is traveling, how far down. I'll ask them, what they've done for us so far. A lot of times they'll come in, having gone to their primary care physician, they'll gotten, say, like some non-steroidal anti-inflammatory medications or a Medrol dose pack and some x-rays, and we just kind of start setting the table and see what comes from it.
So when I use the word mapping, I think of it as, as you're evaluating a patient and someone is saying, I'm getting this sensation that's running down the back of my leg from, my lower back. It's a tingling or it's a numbness. Is that you then try to decide where is that coming from? And that's how the treatment plan is developed, or are you kind of treating the symptom?
Both. So a patient comes in and they start telling me I have low back pain going down the back of the right leg or the front of their leg. That's why I kind of try to ask them to be a little bit more specific. Because there's a dermatomal distribution. So like say the L4 nerve root comes out the back and kind of goes down the front of the leg, or L5 goes down the side, S1 and S2 are down the back of the leg. So I kind of start putting the pieces of the puzzle together there.
Yeah.
Try to tie that in with their x-rays. Usually there's not significant finding on their x-rays. Sometimes there is, but more often than not, it's, there shows some arthritic changes, some degenerative disc disease, things along those lines. And then we kind of put together the game plan. And again, it also goes into what have they done by the time they've gotten to me?
Yeah.
Have they done physical therapy? Have they done at least a home exercise program that was given to them by their primary care physician? And we start from there.
So the imaging is hugely important, correct?
Oh, absolutely.
And is the imaging part of the, like that's the big picture of it? Like sometimes do you ever find that the imaging really isn't matching the symptoms?
Oh, it happens all the time.
Oh, wow.
Yeah.
Does it really?
Yeah.
Oh, my
It
gosh.
happens all the
Okay.
time. I
Okay.
don't know how many times I've had people come in, and even if people come in with an MRI, they'll come in with an MRI and it'll show, like a lumbar disc herniation at L5S1 with a, something on the right-hand side, like a L5S1 disc herniation pressing the L5 nerve root on the right.
Yeah.
But they'll then sit there and tell me they have pain in the left leg. I'm like, all right, thanks
Okay.
a lot. Yeah,
So what is why is that? What happened?
Well, the thing is, and I've said, I don't know how many times I've said this in my practice, like we basically treat the patient, not the MRI.
Yeah.
So kind of irrespective of what the MRI shows, we treat the patient. Just because they have a large disc herniation at one level compressing a L5 nerve root, they still might have a smaller something going on at L3-4 on the left that's causing their pain. So you really have to kind of tie the story, put the story with the MRI, with what they're telling me, and we kind of build from there.
And so you are building a personalized treatment plan for each patient. What approach do you take to doing that once you've kind of put all the pieces of the puzzle together?
So again, if a patient comes in and they have low back pain going in the left leg, and first thing, I'm a big firm believer in physical therapy out of the gate.
Yeah.
Unless they've already done it or if they've done a home exercise program or there are some other prohibitive factors, I'm a firm believer in sending people for physical therapy.
Before you start.
Well, not before, but as we start. So
Okay.
patient comes in, low back pain, left leg, again, depending on what they've done, we may order an MRI, may not order an MRI, but the first thing I do is I want to get them into physical therapy or at least the home exercise program, trying to build core stability.
Yeah.
Because we know that
Makes
if we can
sense.
take some of the pressure off of the spinal column, it may just give the patient enough room on the side of the spinal column where the nerve comes out to get them out of pain. So not every person that comes in that has an MRI with a disc protrusion is going to need an injection or surgery. Sometimes we can just get them better with physical therapy.
Wow, that makes sense. And what are some of the options when you're presenting these personal treatment plans? What are some of besides physical therapy, what are some of the other options that are conservative treatments that you're recommending for patients?
Well, like home exercise program, if they can't do physical therapy. We have a woman in the practice that does acupuncture. I'll offer them acupuncture. I'm a firm believer in. I'm willing to go down whatever route
I've
you
had a
want
few
to go
sessions
down.
with
Have
Dr.
you?
Mariani.
Oh,
She's
that's
amazing.
awesome. Oh, yeah.
And the pins in the ears.
Right.
So good.
Yeah. So I'm a firm believer in I'm willing to go down any avenue you want within reason, right? So if they don't want to do physical therapy and they want to try acupuncture or chiropractic care, I'm willing to go down that road with them.
Yeah.
And if all else fails and it comes to injection therapy, then we circle back and we talk about what we can do from an interventional standpoint. And
so once we get through the different treatment options, whether it's injections, what is your communication with, bringing in a surgeon if you feel that, we've tried this whole treatment plan, they're not getting better? Like, is there a specific time frame that you kind of say, all right, we're going to give this 6 months? Like, is there a standard time frame for treating?
No, for me, it's not standard. It's more patient dependent.
Yeah.
So some people will come in and they're just in excruciating pain. And you get the MRI and it shows a really big disc herniation. And I'm just not sure that's going to get better even by doing an injection or two.
Yeah.
That's a time when I'll have them to get a surgical consult. Especially if there's weakness. We don't like weakness, right? So if you have weakness, we kind of send you to the surgeon and let them decide if they have to, go do something emergently.
Yeah.
However, if we're going through the standard progression, physical therapy, come back and talk about injection therapy, what I'll do is I'll do an injection, ask to see them back in the office 2 weeks later. And depending upon how much their pain has improved, we kind of start going down another path. So if they come back and tell me after their first injection, 60, 70% better, I talk about doing a repeat injection and see how they do with that.
Okay.
And then depending on how they do after the second injection, then we kind of, start going down different pathways. If they do great, they just keep going and we just kind of send them on their way and hope we never see them again.
Yeah.
But some people will come in after an injection, 1 or 2 injections. Like just for today, for example, a patient comes in and says, you know what, I did great for 2 or 3 days after the injection. I'm just like, well, so I say, but then that's the kind of patient I say, let's try a second one. But I also, at the same time, I say, you know, what we should probably do is get you a surgical consult.
Yeah.
Right? So I'll put them on basically, parallel paths. Talk about doing a repeat injection. And then I also want them to get that surgical consult, because what I don't want to have happen is I don't want that patient to come back 2 weeks after the second injection and tell me that they're right back to where they were. Like they got like 3, 4, 5 days relief and their pain is just as bad before the first injection. Because if I've done that, and I've just wasted another 2 to 4 weeks. So we have them go down the path of maybe a repeat injection, have them get the surgical consult, and we just kind of go from there. So the surgeons are pretty well tied in.
So that's a great segue actually into a question I'm curious about is when someone comes in for injections or pain management, does the treatment somehow allow the body to heal itself, or is it an ongoing process? Like how is that determined? Like I have a quick example of my own self. Years ago, I had, what was it called? Something in my shoulder that I had cortisone injection for, begins with a B. I forget what that was.
Bursitis.
Yes, thank you.
You're welcome.
I had that. I went and I had 1 injection and boom, I'm done. Good.
Life is
Never
good.
had it come back again. So I was 1 and done.
Right. Well, that's my hope. My hope is that every patient comes in with low back pain going their leg. I do 1 injection. They come back. They're doing great. I never see them again.
Yeah.
That's the hope.
Yeah.
Doesn't always work out that way.
Right.
Sometimes it takes a second injection. Sometimes a third. I kind of give the analogy of like there's a bucket, there's some flames in the corner. I throw a bucket of flames on water. All the flames go out. The water dries up. No more flames. No more water. No more inflammation. Just let it go.
Yeah.
Now that flame may erupt. You've all heard about the fire that was under control. Then we throw a second bucket on and see how they do the second bucket.
Yeah.
By the time the third bucket comes around, the third bucket doesn't work. I call in the fire department. I call in the surgical team and see what they have to say.
So sometimes it could just be a flare-up of a nerve that just needed some attention and
absolutely.
kind of needed some water thrown on it
exactly.
to calm it down.
So basically what I tell people, look, it's all about controlling inflammation.
Yeah.
Right? Just because, again, going back to this, people walk around all the time with abnormal MRIs who don't have pain because they don't have the associated inflammation. I can't tell you the number of times people have come in and I have low back pain going in my right leg, and you get an MRI and it shows an L5-S1 disc herniation compressing the right L5 nerve root, perfectly ascribes their pain.
Yeah.
You look 2 levels above and you'll see a left L3 disc herniation pressing the left L3 nerve root, nothing on the left.
Wow.
And so it's all about inflammation.
So you have to really look at the whole picture.
Well, I try to.
Yeah. I mean, it's kind of just, I like that idea of looking at the whole picture, because if you're just looking at that one isolated area, you might be missing something above or below.
Right.
Right?
Yeah.
Yeah. What are some of the advancements in pain management that you've recently been excited about?
Oh, there's a bunch of stuff coming out in interventional.
Really?
Oh, yeah, it's great. And I started doing
Nice.
a couple of the procedures and actually been doing really well. One of my favorite things is spinal cord stim. Now, spinal cord stim's been around for 20, 30 years, but it's a great modality for people who have already had surgery, who aren't necessarily a candidate for repeat surgery, or the surgeon's like, there's nothing I can do for you, or they're too frail or too old. That's a great option. Now, that's an older technique, but some of the newer stuff is peripheral nerve stimulation. So instead of putting someone a spinal cord stimulator, we put the leads into the spinal column. With this peripheral nerve stuff, we're basically putting small little, tiny little, like fishing line type of stimulators over the patient's nerve.
Wow.
And burying it and then putting a little impulse generator on. They wear it for 60 days. And you would think, well, great, 60 days, I get good relief and then you take it out. But we found that basically it's changing the signal to the brain. So people were putting these stimulators in, pulling them after 60 days, and people are still getting months and months of relief.
That's amazing.
So that's a fun one too. And there's another one, it's called the mild procedure. It's minimally invasive lumbar decompression, which has been great as well. So one of the causes of low back pain, if you ever see the little old ladies walking in the grocery store, leaning on their shopping cart.
I always think it's osteoporosis or something, right?
That's like probably spinal stenosis. Oh. So the spinal cord goes down through the spinal column, and there's a ligament in the back that can kind of start to press in. And so when people who have symptoms of spinal stenosis, they have increasing pain when they walk. They're going to feel better when they're sitting forward in their chair. They're going to feel better leaning on the shopping cart. Low back pain going into the legs. And if you get the MRI, you can see this ligament and flavum thickening. This minimally invasive lumbar decompression, a pinky nail size incision. We put this little trocar in, and we can actually, I kind of tell people it's kind of like dredging a river. You need to get this ligament, and it's almost like an ice cream scooper. We scrape out this ligament and flavum, debulk it, and what it does is it reopens a spinal canal. And I've had people come. I had one guy. This is not the norm. I had one guy come back 3-4 weeks afterwards, complete resolution of his symptoms. Completely new person.
Amazing. And how long had he been suffering?
Years.
Oh my gosh.
I know.
That's life changing.
Yeah. Oh, absolutely.
Wow.
Yeah, 100%.
I'm going to have to share that with my brother because he was just diagnosed with that.
Yeah.
Spinal stenosis. He sits all day and, just, wow, that's crazy.
Oh, yeah.
That's a great patient story.
It's a great procedure. It really is.
Oh, my gosh. So that's like the human side of your practice that is, you have to bring some compassion, right, to your practice. Is that, how do you find that you're supporting your patients when they're coming to you with agonizing pain and, you're trying to just bring them through this process?
Yeah, it can be hard.
Yeah.
It's hard. When people come in, these people have been suffering for years. Because we get way more people who are kind of in that situation than the person comes in and has an acute situation.
Yeah.
It's tough. It's hard to deal with those people. And you're just trying to give them hope.
Yeah.
Right. I worked for one place that the guy called the place something pain control. And I'm like, man, I'm not sure that's the right answer.
Yeah.
It's like pain control and pain management are very separate things. I'm here kind of basically just trying to mitigate, trying to at least, give them something. Because if we can cut someone's pain in half with a lumbar epidural and they get 6-8 months out, most people will take that.
Yeah.
But it's hard when people come in there. We're talking about people coming in dealing. We get maybe an 81-year-old woman who comes in.
Oh gosh.
She's been dealing with pain since, they'll come in with stories like, well, I've been having pain for 40 years. And you're like, man, this is not going to be an easy one to crack.
No. And they're losing sleep and, their quality of life is nothing.
Yeah. Yeah, the sleep is the worst, right?
Yeah.
It's the easiest way to make someone psychotic is to sleep deprive them, right?
Yeah,
I mean, it's terrible.
Gosh, that's horrible. I mean, I love your successful patient story. That's just that's a real good feel good.
Oh yeah,
story.
Yeah, that was pretty impressive.
Yeah. And so for patients that have been to a different pain management specialist and you're their second opinion, so to speak, what are you finding that they found with their first attempt at the previous practice that maybe was unsuccessful?
Well,
was it the approach? Was it the treatments? Just not attentive, looking at the whole picture? Is there anything identifiable?
Sometimes yes, sometimes no. Sometimes no matter how good you are and how attentive you are, some people, you're just not going to improve on some people's position, right?
Yeah.
There are very few people out there that I don't trust. I mean, most people come in for a second opinion. I always ask them to obtain their records from their prior pain management physician because I want to see what worked and what didn't work and see what they were able to do or not able to do. Because if they said they had seen someone 4 or 5 years ago and they have, we were going back to the model procedure, and they have severe central canal stenosis from ligament and flavum, well, there's something we can offer them.
Yeah.
Not every pain management physician offers mild or spinal cord stim. So there may be some things in my bag of tricks that I can offer them that they didn't have available then. So it's really patient dependent.
So is it a joint decision when the patient is really just not improving and they have to move on to surgery? I mean, is it something that you kind of put your foot down and say, listen, we're just not making the progress that we had hoped for. I think we should look at, the next step. And then you interact with the surgeon. How does that work?
Yeah. So, I mean, when people come in after, like, say, their second or third injection and they're not getting any better and I basically exhausted my bag of tricks, I'm like, listen, that's when we kind of go back to like, okay, here's the fork in the road.
Yeah.
Our options are, we can have you see one of our folks that do the medication management. And when I say that to them, and I make this very clear, it's like, I'm not talking about sending them or you to them to talk about narcotics.
Yeah.
There are a lot of other medications out that are not a narcotic that are very good for low back, whether it's gabapentin, Cymbalta, Savella, things like that are non-narcotic. So I make that very clear to them. I'm not sending you to somebody just to write for opioids. I want them to try whatever medications they feel or deem fit to try those. You know, we've already done all the conservative stuff. We've done physical therapy. We've done this injection. We've done that injection. The other option is we send you for a surgical consult.
Yeah. And how do you interact when you're handing that patient off? Is there a consult that you have with the physician, or is it on them to just look at the patient's records and, you know, all of your notes and such?
Yeah, no, usually because we have, you know, 2 spine surgeons in our group who I implicitly trust.
Yeah.
And usually I'll kind of give them heads up saying, hey, look, I'm sending you a patient. They have this, and this.
Yeah.
But, you know, they have access, obviously, to everything. Since they're in our system, they have access to the MRIs, the CT scans, what injections have been done. And, you know, but I basically give them a heads up as to, you know, this one's going to be coming to you and see what you can do for her or him.
So medicine keeps moving forward. What do you see as one of the, you know, what do you see as futuristic type of treatments if you have a crystal ball? How do you, you know, how do you see patients' pain management evolving? Is there anything that comes to mind?
Well, that's what I'm saying. There have been so many advances in interventional pain management just within the last, you know, say 10 years.
Yeah.
Like even spinal cord stimulation has become significantly advanced. Before we had to produce a paresthesia, so we would put the leads into the epidural space. And patients would have to go around, instead of just having pain, they would actually have to feel a buzzing or a tingling just to cover the pain.
Yeah.
Now we just have programs where they can just eliminate the pain. So things like that. And then with the mild procedure, there are other procedures coming out online. And I was just reading about something over the weekend with virtual reality and AI that is going to be really interesting to see how that kind of starts to play in.
Okay.
It's really more from the humanistic approach.
Okay.
It's like virtual reality somehow, with biofeedback and wearable technologies. So I think that's going to be a big player in the future for pain management.
Very interesting. Very interesting. So if we were to wrap up with some final advice for you to give some listeners that would really give them some hope. You know, there's a lot of people out there, I'm sure, that are dealing with pain and they just feel like it's part of life now, really discouraged. What would be your message to them?
Come see us. I read it as I'm a little bit, I probably go a little bit too far overboard with people, but, you know, I always have a kind of junkyard dog mentality of going down every possible road for people, leaving no stones unturned. So I would say, you know, just because things haven't worked in the past, don't give up. There are new technologies. We have maybe some more advanced techniques that weren't available for you in the past. Yeah. And then come see us and see what we can do for you.
Yeah. And of course, it's always nice to get a second opinion anyway.
Oh, yeah.
You know, so that's always nice. Dr. Fitzhenry, thank you so much for joining us
You're
today.
very
You've
welcome.
really
Thanks
provided some great expertise. And I love the futuristic type of things, or even just the new stuff that has been introduced in that success story is really
great.
nice. Really, really nice. For our listeners, if you are struggling with pain or you know someone who is, you don't have to suffer in pain. You can call us at 856-690-1616 or reach out to us at poasnj.com to schedule an appointment. Thank you for listening with today's episode of Bad to the Bones. Don't forget to subscribe and share this with someone who might benefit from it. Until next time, we hope you stay strong, stay active, and stay bad to the bones.